restful and rejuvenating Thanksgiving vacation. We're going to start with reviewing, it actually wasn't even last week, we're going to review from pre-break. I think it'll be good because when you go to study for the exam, you won't be like, wow, I've never seen this before. So we're going to bring it back real quickly. So, we have HW, who's a 90-year-old, 45-kilogram female with recently diagnosed CHF and CKD. She's admitted to the hospital complaining of weakness, dizziness when standing, and fatigue. Her serum creatinine is found to be 4, and her BUN is 80. Her home medications include carvedilol, lisinopril, Lasix, and simvastatin. And you might look at her heart rate, which is elevated at 110. So I know that haven't even looked at this for a while, so I will give you one hint. This is hemodynamically mediated renal failure, which is a type of pre-renal failure. But go ahead and tell me if you were given this case on an exam or in life, what would point you towards this renal failure being hemodynamically mediated? Remember that hemodynamically mediated means interfering with blood flow to the kidney. There's no actual kidney damage. Go ahead.
Her BUN to serum creatinine ratio is 1:1.
Beautiful. She has an elevated BUN to serum creatinine ratio. That means that she's holding on to all of the fluid, as much fluid volume as possible, and BUN follows fluid, so that's why the BUN has become disproportionately elevated. Her body is essentially acting like it's dehydrated because it's trying to increase the blood volume to get more blood flow to her kidneys. So excellent. That BUN to serum creatinine ratio is a big tip-off. What else is a tip-off that this is hemodynamically mediated? Which medication would you suspect if you were going through the med list looking for something that could cause kidney injury?
The lisinopril, since it's an ACE inhibitor.
Beautiful. So if you saw that she was also on an ACE inhibitor or a diuretic or an NSAID, those are medications that are associated with decreased blood flow to the kidney. So looking at the med list can help tip you off as well. Then I would also look at her past medical history. Because she has CHF, that's a condition that is already associated with some low blood flow to the kidneys. So people with CHF are really prone to developing this type of kidney injury. Other patients that have decreased blood flow to the kidneys are your cirrhotic patients, dehydrated patients have decreased blood flow to the kidneys. So always take a look at the past medical history to see if she's someone who might be at risk for that. Finally, always listen to what she's complaining of. So weakness, dizziness when standing, and fatigue sounds a bit like dehydration, so always look at what the patient is mentioning too. And I mentioned the heart rate because dehydrated patients tend to get a little tachycardic because their heart is working harder to get blood flow to the organs. All right. So which part of the kidney is affected in the pre-renal type of kidney injury? Pre-renal. It's just the blood flow, right? Nothing actually happens to the structure of the kidney. Her big risk factor for drug-induced nephrotoxicity was having that CHF in her past medical history, and of course being elderly didn't help us as well. We suspected that the lisinopril was the cause of her AKI. Honestly, it's usually a combination of things. Like she probably got dehydrated, wasn't feeling well, and was on the ACE inhibitor, and that kind of tipped her into hemodynamically mediated renal failure. We probably could have prevented this by making sure she was well hydrated and starting with, of course, low doses of lisinopril. She had recently been diagnosed with CHF and was started on, I forget what dose here, 20 mg daily of lisinopril. We probably could have started with a lower dose to try and prevent that. And then for anyone with pre-renal type of acute kidney injury, so remember anyone that has decreased blood flow to the kidneys, to treat that type of acute kidney injury? What are you going to do to get blood flow back to the kidneys? Yeah, give IV fluids to increase your blood volume. And of course, we're probably going to hold the lisinopril for now. We're going to talk today about how much I love ACE inhibitors, but we'll hold it for a little bit, let her kidneys get back to normal, and then restart it at a lower dose probably. So I threw in a slide. This is just from the last lecture, but it's a good one for when you're reviewing the causes of pre-renal hemodynamically mediated kidney injury. Remember that your kidney relies on prostaglandins and angiotensin II to affect the afferent and efferent arterioles and keep the intraglomerular pressure, to keep your kidneys well perfused. And so when we inhibit prostaglandin production with NSAIDs, we mess with the blood flow from the afferent arteriole. And when we inhibit angiotensin II with ACE inhibitors, we mess with blood flow with the efferent arteriole. All right, here's our second case. We've got a 41-year-old IV drug user who is found to have endocarditis caused by MSSA. This is very common because IV drug users are putting needles directly into their veins, so bacteria can kind of just waltz down that needle into the bloodstream and easily affect the heart. She's prescribed nafcillin, 2 grams IV every 4 hours for 4 weeks. And guess what? If you are an IV drug user, we can't send you home because we don't want to send you home with an IV medication, a direct IV line that you could use for other purposes. So let's say that she stays in the hospital for these for this treatment course, and 2 weeks later she develops a rash and a fever. I'm going to go ahead and tell you, because it's been a while, that this is acute interstitial nephritis. Acute allergic interstitial nephritis. You guys tell me what would have tipped you off if you came across this clinical case on an exam or in life. What would have steered you towards an allergic type hypersensitivity reaction? Yep, it was 2 weeks later. Right, so it does. That type of reaction does take some time to develop because your body has to make antibodies to that drug. So the fact that it was a delayed response does point us towards acute allergic interstitial nephritis. What medication do you think it is? Clearly, you think it's which one? If it was 2 weeks later and we started a med. Which med on her list most commonly causes allergic reactions? Yep. Right. I would go after, if you think it's this hypersensitivity reaction, I would go after things that you would think of as potentially causing allergic reactions. So you usually go with the antibiotics, penicillins, sulfonamides. It's less likely to be the Tylenol that she used or the famotidine. There's one more huge tip-off that this, well, there's a couple more tip-offs that this is acute allergic interstitial nephritis. What do you see in the urine that makes you think allergic reaction? What does your body produce when you have an allergic reaction? What, if I said it started with an E, would that help? Beautiful. So eosinophils are a big tip-off that this is acute allergic interstitial nephritis, because that is an immune modulator produced by your body during allergic type reactions. I would say the last tip-off that this is interstitial nephritis is that the patient has a rash and a fever. These are systemic manifestations of a hypersensitivity reaction. So what part of the kidney is affected in AIN? It's right in the name. Interstitial. Beautiful. The interstitial interstitium is what is getting inflamed. Remember, the interstitium is the tissue that surrounds the tubules and the glomerulus that helps the kidney maintain tonicity. As far as risk factors for this type of nephrotoxicity, it's an allergic reaction. We have trouble predicting it. So there was probably no big risk factor that could tip us off. We decided that it was nafcillin that caused her renal failure. There's really no way we could have prevented it because we didn't know that she would have this type of reaction. And does anyone remember how this type of renal failure is managed? Let's say somebody had a really severe allergic reaction. What would you, first you would try antihistamines, but what might be next? Yep. That's very severe, you're right. That was not what I was going for, but because this person is not going to have trouble breathing, so we don't have to worry so much about anaphylaxis type reactions. Yep.
Steroids.
Beautiful, steroids. So number one thing to do is to DC the nafcillin, find a different antibiotic for this woman. But in very severe cases of interstitial nephritis, we might prescribe a short course of steroids to try and speed the recovery of the kidneys. So here's this is just a slide I stole from before break, reminding you of acute allergic interstitial nephritis. It has that delayed onset like we mentioned. You can see some eosinophils on this kidney biopsy that I have here. And then remember the classic triad of symptoms are there's these systemic symptoms associated with this, which is fever, rash, and joint pain. All right, moving right along. Now we've got a 32-year-old female who's got flank pain, dysuria, urgency, hematuria, and fatigue for 3 days. She is HIV positive. She's on Bactrim, zidovudine, didanosine, indinavir, itraconazole, and Tums. And her urinalysis reveals some blood, some white blood cells, and some granular casts and crystals. The crystals are in a sheaf and rosette pattern. I won't make you memorize the patterns, don't worry. But reading this case, what is clearly the type of kidney injury that's occurred if you've got crystals in the urine? Obstructive. Beautiful. It's an obstructive type of kidney injury. It would fall in the post-renal category because it's either clogging the ureters or maybe the tubules. And what drugs would you target in her med list that could crystallize? I know it's in your notes too. Yep. Yeah, indinavir, very good. I wouldn't make you recognize the patterns, but that's a very common cause of this type of acute kidney injury. I would not guess Bactrim, even though Bactrim can crystallize, she's on such a small dose that I would not guess that one. Remember that with Bactrim, in order to get crystals, you need to be on really high doses of that medication. All right, so we think the indinavir is the cause of her renal failure. We think this is an obstructive type of AKI. How could we have prevented this type of acute kidney injury? What do you guys think? There's not a lot we could have done, but what would have sort of kept the crystals moving through the kidneys? Yep. Beautiful. So that's why when you guys do dispense Bactrim, do you see the little warning label that says drink with a full glass of water? That's to prevent these crystals from getting stuck. They put it on every Bactrim prescription, no matter what the dose is, but they want you to stay well hydrated. As far as management is concerned, if we can switch to another drug, we will. We'll definitely hydrate her and try and get the obstruction out that way. There's just the reminder slide when you're thinking about which drugs can crystallize. All right, I think this is the last one. We have RW. He's a 75-year-old male with a metastases. Do you remember what type of acute kidney injury IV contrast dye might cause? I know it was a while ago. So it causes acute tubular necrosis, just like aminoglycosides do. So when you're studying, be sure to know IV contrast dye and aminoglycosides cause acute tubular necrosis. Okay, I'll stay on the case, but the question is, what risk factors would have tipped you off that this person might get acute tubular necrosis from their contrast dye? There's two classic ones that you're going to want to remember for the exam. Does anyone remember? So it's go ahead. Metformin we should definitely hold beforehand, because if he goes into AKI, we don't want him to develop lactic acidosis. But that's not necessarily a risk factor for developing this type of acute kidney injury. But good point, we will hold that metformin. So it's patients who have diabetes, and the diabetes is bad enough that they've also developed some CKD. If you see a patient that has diabetes and CKD, like 50% of the time that we give them any IV contrast dye, they're going to go into AKI. A normal, healthy young adult probably won't get AKI from the IV contrast dye. It's those diabetics with pre-existing chronic kidney disease. And then I know it's in the answers in a couple of slides, but what is the only intervention that has been shown to prevent IV contrast dye-induced nephropathies? Okay, we can peek. IV hydration. So we reviewed, there's a big controversy about whether you should use sodium bicarb or normal saline for your hydration, but no matter what, make sure the patient gets IV hydration. That's the most important thing. All right, so just to help you study, here's an example of a test question I might give you. I'm going to give you a bunch of urinalyses, and I want to see if you're able to answer questions based off of it. So if I just gave you this and no other information, what type of acute kidney injury do you think this patient has?
Obstructive?
Yes, obstructive, because the crystals tipped you off. So when you look at the urinalyses on the exam, look for those classic indicators that I mentioned. So, with pre-renal failure, maybe you would look and see that the specific gravity was high. For acute tubular necrosis, look for some casts. So just get used to looking at a urinalysis and finding something to tip you off. All right, any questions about AKI? Hopefully that was a good mini review. I think of all the lectures that I have, that one is the most information dense. So start reviewing that one sooner rather than later so you don't feel overwhelmed. All right, ready to move on to chronic kidney disease. And I'm going to try and liven things up a little bit with the video. Hopefully this works.
Yesterday, I was your best friend. Tomorrow, I could be your worst enemy. My influence is absolute. I can take down your heart, your lungs, your liver. Your skin and bones are nothing without me. Do you know what the sad part is? You don't even know me. I am kidney.
Know your kidneys. Know your GFR. Ask your doctor. Arizona Kidney Foundation.
So the other one is very similar. It's just the lady in the grocery store. I guess you can watch it.
I influence every little aspect of your inner world. Take care of me, and I'll return the favor. Overlook me, and I just might decide to poison you. Listen, hear that? Of course you don't. That's why they call me the silent one. I am kidney.
Know your kidneys. Know your GFR. Ask your doctor. Arizona Kidney Foundation.
Okay. So I'm not sure if fear tactics was necessarily the right road, but I did think it was entertaining. I like to think of our kidneys not as, I don't know, serial killers, but our friends, but we need to make sure that we take care of them. It is known as the silent killer because we often don't see the signs and symptoms of kidney disease until your kidneys are on the verge of failing. All through the early stages of CKD, your kidney steps up and makes sure that you don't feel the symptoms, which is great, but it means that by the time you start thinking something is wrong, you may be very advanced in the disease process. So we're going to spend some time today talking about who should be screened, and you may find yourself volunteering at kidney screening events. I think it is not long that we will have the ability to screen for kidney disease right in a retail pharmacy as well. So it is an important thing to be aware of. So today we'll of course have to define CKD. We'll talk about the different stages and who should be screened. I'm going to try and explain a lot about how different disease states hurt the kidneys, so pay attention to etiology as well. And then we'll focus on interventions to slow the progression of kidney disease. On Friday, we'll talk about when your kidneys do fail, all of the crazy complications that occur, the severe anemias, the bone disease, all the things that the kidney in the elevator was referring to. Here are the objectives. I'm not going to necessarily go through them one by one. They're just here to help you study for the exam. I guess if I had to point out a couple biggies, I do think when you're studying, it would be important to look at the pathophysiology of why kidney disease occurs. If you learn the whys, I think you will not have to memorize as much. So pay attention to why things happen, and I think you'll feel more comfortable prescribing things because you know the why behind it. And then, of course, be sure that you do have a working knowledge of the interventions that can be taken to slow CKD. So be sure to know your specific blood pressure goals, your lipid goals, and your hemoglobin A1C goal. And we'll review all of those today. So every good lecture has to start out with some definitions. So let's take a look at what chronic kidney disease is. You can be diagnosed with chronic kidney disease if you have one or the other of these things. Either you have a structural abnormality or markers of kidney disease, or you can have a GFR less than 60. So either there's some sign of kidney disease or your GFR has clearly been decreasing. Now the word chronic is in there, so these markers of kidney disease or this decreased GFR needs to persist for greater than or equal to 3 months before we call it chronic kidney disease. So for example, if I load you up with aminoglycosides and give you acute tubular necrosis, I'm not going to say you have chronic kidney disease until I wait for 3 months to see if your kidneys recover or not. If they don't recover, then I gave you CKD, and you can sue me. When I say markers of kidney disease, I'm mostly talking about protein in the urine. Small amounts of protein in the urine are called microalbuminuria, and that still warrants a referral, but it's not as bad as having large amounts of protein in the urine, which is called frank proteinuria. Blood in the urine can also be a sign of kidney damage, especially if it's combined with protein in the urine. Blood by itself in the urine can be a marker of kidney damage, but it's much more frequently a sign of a urinary tract infection, a kidney stone, or even bladder cancer. The first signs of bladder cancer are blood in the urine. So if you see that combo of blood and protein, that's definitely specific to kidney disease. Another marker of kidney damage would be casts. Remember that casts are these things that appear in your urine when cells of the kidney die, slough off, and travel through your tubules and are peed out. So they're actually tubule shaped. because they are just dead cells that had to travel through your tubules to your ureters to be eliminated. So if you have cast in your urine, that means cells in your kidney are dying somewhere. For acute tubular necrosis, the tubular cells are what's going into your urine, and those make muddy brown casts, just as an example. Ooh, one sign of advanced kidney disease is really foamy urine, because proteins, if you have a large amount of proteins in your urine, when they hit water, they have this foaming effect. Now, when I first heard this, I diagnosed myself with CKD. Just so you know, it's really foamy. Like the foam will be coming out of the toilet. That's how foamy it is. When we're trying to evaluate how much protein is in someone's urine and when to be concerned, one thing to do is to look at a urine dipstick. Remember that this is just a piece of paper with some chemicals on it that when you dip in the urine, if there's proteins in the urine, there will be a chemical reaction that will change the color of the dipstick. So it will tell you that there are proteins in there. That's a quick and easy way to do screenings. I think if we have them in retail pharmacies, we'll be doing the dipstick tests. The other way to diagnose having protein in the urine is to take a urine sample and measure an albumin to creatinine ratio. An albumin to creatinine ratio of greater than 30 is a sign of chronic kidney disease, and you don't need to memorize that number. Just wanted to be thorough. One key part about these definitions is that both of these tests need to be confirmed on 2 different occasions, at least 3 months apart. This is because some people get protein in their urine whenever they get dehydrated, or whenever they work out really hard, or if they have a stressful time in their life, maybe they're taking an exam. So we don't react to one finding of protein in the urine. We just make sure that we follow up to make sure it's not something worse. My husband probably doesn't want me sharing his private medical information for the whole class, but the last time he went into his primary care physician, they tested positive on the dipstick for protein in the urine. And his doctor called him, said they wanted him to come back. He was like, I don't have any risk factors. I don't really believe this. And I said, no, I teach the renal module. You're going back in. And it was clean. So it's not uncommon to have one finding of protein in your life. Next, let's talk about the stages of chronic kidney disease. Do you guys remember what equation is good for helping you stage somebody's CKD? So not dosing drugs. Yep.
MDRD.
Beautiful. So the MDRD will actually tell you what stage somebody is in when you're trying to find their GFR. And there are some great MDRD calculators out there on the internet, so you don't have to, do that math yourself. All right, so stage 1 and stage 2 CKD refer more to patients that have regular GFRs but have some kind of marker of kidney damage, like the protein in the urine, or maybe imaging shows that somebody has a smaller than normal kidney. In these early stages, your GFR is normal, or it can actually sometimes even be increased because your kidney has noticed that there's been an initial insult and actually stepped up its functioning even higher to try and make up for it. So sometimes we even see people with fantastic GFRs because their kidney is working overtime to try and make up for that injury it saw. Moderate CKD starts to occur on stage 3. That's when your GFR falls below 60. And when you hit CKD stage 5, this is important. We stop calling it CKD stage 5 and we start calling it end-stage renal disease, or ESRD. Those are your dialysis patients. So if I ever refer to an ESRD patient or a dialysis patient, I'm talking about someone with a GFR less than 15. Now, I don't want you to go through and memorize the numbers for each stage. I think the 2 important numbers to know would be when your GFR falls below 60. That's sort of when we get concerned that you're in the CKD range. And when your GFR falls below 15, that's when we start thinking about dialysis. The rest of it you can always look up when you're a practitioner. So now we're going to talk about screening, and then we'll take a break and talk about the progression, how to slow the progression of CKD after the break. So again, we have a big emphasis on screening, people using scare tactics, people using ads, trying to get it known out there that CKD is something that we want to catch early because the symptoms don't occur until much later. So in order to talk about who should be screened, I'm going to talk about the risk factors for developing CKD, and then I'm going to talk about how those risk factors can damage the kidney. So the risk factors can be divided into 3 types of factors, according to DiPiero. I like it. There are susceptibility factors, initiation factors, and progression factors. And what we mean by those is susceptibility factors are things that don't necessarily hurt the kidney, but they make you at increased risk of getting CKD. Initiation factors are actual conditions that hurt the kidney and start the process of developing CKD. And progression factors are factors that, after the kidney is initially hurt, cause the chronic kidney disease to progress. So it continues to damage the kidney over time. So for susceptibility factors, advanced age is a big one because people of advanced age tend to have more atherosclerosis, and you can get atherosclerosis of your renal arteries and your glomerulus as well. People who were born with 1 kidney or a small kidney, or maybe were just very low birth weight when they were born, tend to have less nephrons than a healthy individual. And so if you start out life with less nephrons, you're more susceptible to developing chronic kidney disease. Racial and ethnic minorities, the big ones are African Americans, Native Americans, and Hispanics have increased incidence of developing CKD, and this is even if they receive the exact same treatments as other people. So we're not sure if it's a hereditary factor or an environmental factor that comes into play, but certain racial or ethnic minorities are at increased risk. Family history is a big one. These kidney diseases do have a strong hereditary component. So when we do have kidney screenings, we often advertise at dialysis clinics and say, have all your relatives come in, we'll screen them. Because that's a good way to get to people that have that risk factor. Low income or education probably has to do with having decreased access to care and decreased access to healthy foods and things like that. Any sort of condition where you have systemic inflammation, so a lot of autoimmune conditions can put you at increased risk for kidney issues, and we think that dyslipidemia does as well. Now we're going to spend a lot of time on the initiation factors, but diabetes is number 1. I have some slides on this later, but the way that diabetes hurts the kidney is that the sugars in your blood actually bind to proteins and lipids in your kidney, causing them to function ever so slightly differently. And since they're functioning differently, they're much more prone to becoming damaged. So it's the actual glucose binding to proteins in the kidney. Hypertension causes CKD in the way that you would think. Anytime you have something that's putting pressure on your blood vessels and causing damage, that same pressure is going to be on your renal arteries and on your glomerulus. Remember, the glomerulus is just a little ball of capillaries. So anything that affects your blood vessels is going to affect your kidneys. And then, of course, glomerulonephritis is usually autoimmune related, and it's not as common as diabetes and hypertension. So this figure is getting old. I looked for a new figure last night, but they haven't published a new one since then. But trend upward, and they do, so this is still a good figure to study. As you can see, on the x-axis here we have the year, and on the y-axis we have the number of patients in thousands that are developing end-stage renal disease, or CKD stage 5. You can see that back in the 80s, the purple line is on top. So in the 80s, glomerulonephritis was the most common cause of kidney failure in the United States. But with the obesity epidemic going on, you can see that diabetes and hypertension have rapidly become number 1 and 2 most common causes of end-stage renal disease in the United States. And this has continued to elevate in more recent years. So no matter whether your initial kidney injury was from diabetes or hypertension, there is a common cycle that occurs once you have a renal injury that sort of causes the CKD to progress. So I have this written out on 2 different slides so you can pick your favorite slide when you're studying. But here's one way to think about the final common pathway. You have a renal injury from diabetes or hypertension. This injury takes out some of your nephrons. Your kidney is a very happy-go-lucky organ and says, don't worry, I'll step up and filter faster with my remaining nephrons so that your GFR doesn't decrease. The way that it filters faster is by increasing that intraglomerular pressure. So it clamps down on the efferent arteriole and increases that intraglomerular pressure. However, anytime you have an organ that is working harder than normal, you are going to have bad things happen over time, usually hypertrophy. So when you have your kidneys filtering much faster than normal, there's a lot of wear and tear that happens to the glomerulus because it's just filtering so much harder than normal. This wear and tear that happens on the glomerulus allows proteins to leak through. Proteins are toxic to tubule cells. So when proteins get out of the glomerulus and hit the tubules in the kidney, this causes a lot of inflammation and cytokine production. The inflammation leads to renal scarring. More nephrons are lost, and this process begins again. So whenever there's an initial hit to the kidney, your kidney tries to step up by hyperfiltrating, but in the end, it leads to a further reduction in GFR. I know that this is a lot to take in right now, but be sure to, when you study, walk yourself through the cycle and convince yourself that once there's an initial injury to the kidney, there's this progressive cycle that continues, and it has to do with proteins getting out and being toxic to your tubule. This is the ugliest slide ever, but I just tried to write that out so that when you're studying, if you need a written explanation of that chart, it will be in there. Just remember, initial kidney injury, nephrons step up, but anytime you've got the nephrons working harder than usual, they can become hypertrophied and leaky to proteins, which will then cause more kidney damage. Okay. Any questions about that right now? You can email me if it becomes too confusing. So here, I'll show you the results of this study, which was very, very shocking when it was published a long time ago, in 2004. They found that patients with chronic kidney disease are actually more likely to die than to have their kidneys fail. That's illustrated in this figure here. We have different GFRs. I guess this is the best GFR. And then here we're heading towards dialysis. The light blue bars represent patients who have died, and the red bars represent patients that ended up having their kidneys fail and needing dialysis. So the reason that this is a strange and interesting finding is that we used to think that people died because their kidneys failed. But here, this study showed that people are dying well before their kidneys are failing. So there is something else going on. That something else that's going on is cardiovascular disease. Patients with CKD die of cardiovascular disease much more commonly than they do from kidney failure itself. This was shocking. On this figure here, we have just different types of cardiovascular issues that a patient can have, and the population is broken down by GFR. So the patients with the red or this purpley column here have a pretty good GFR of greater than 75, and the people with the light blue column are the people with the worst GFRs. And you can see across the board, the worse your GFR is, the more likely you are to have a cardiovascular event. So that's another reason why screening is so important, because not because we think your kidneys are going to fail right away, but we need to do a really good job of modifying your cardiovascular risk factors to try and prevent your early demise from cardiovascular disease. So just to sum it up, cardiovascular disease is the big killer of patients with CKD. It's not the renal failure, it's that their hearts are pooping out. There's a lot of confusion about why kidney disease would equal heart issues, but what we've come up with is that not only do patients with CKD have the traditional risk factors that you learned about in cardio, like older age, male sex, hypertension, dyslipidemias, but having chronic kidney disease sets them up with some non-traditional risk factors for cardiovascular disease as well. So for example, the kidneys are responsible for producing erythropoietin, and as your kidneys start to fail, you can get very, very severe anemias. So these patients' hearts are working a lot harder to get oxygen throughout their body. These patients, if they stop peeing, can become very fluid overloaded. That's not good for your heart either. Patients, and one big one that we'll talk about on Friday that always really, I always think is so strange, is that when your kidney function declines, your bones start to dissolve into calcium and calcium and phosphate crystals can crystallize in your heart. So your bones are actually moved from your bone area to your heart area, causing cardiovascular issues that way. If that doesn't make sense, don't worry, we'll talk about it a ton on Friday. But these patients with CKD, their disease state is causing all of these different alterations that can cause heart issues that are different than the traditional heart issues that you learned about in cardio module. All right, so we'll do a clinical case, and then I think I have a break built in. Yeah. All right, so we have Joe. He's a 68-year-old welder. Past medical history of an appendectomy, hypertension, elevated cholesterol, type 2 diabetes. He's a smoker. He does consume a whole, must be a, binge drinker, because he does a case of beer on the weekend. He has a family history of cardiovascular disease and a blood pressure of 149/84. What are some of his risk factors that are going to put him at increased risk for developing CKD? Some of these are low-hanging fruit. Go for it. Diabetes, number 1. What else?
High blood pressure.
High blood pressure, number 2. Some other things so those, be sure to know number 1 and 2. Some other things that probably aren't helping him out would be being a smoker. And his family history of cardiovascular disease doesn't make him at increased risk necessarily for kidney disease, but it points out to me that I probably want to screen him and decrease his risk factors for cardio issues as well. Oh, yep, so here's another know your GFR type ad. Do you guys know your GFR? I don't know my GFR. I should ask my mom. when you're thinking about which patients you want to screen for CKD, look for patients who are of older age. Oh, I guess that was one we missed with Joe. He was 68. And let's say that if you're above 65, you should probably be screened for CKD. Anyone with diabetes should have close monitoring because we really want to prevent CKD in those patients. Anyone who's hypertensive, anyone who is a U.S. ethnic minority status because of either a hereditary or environmental thing, they are at increased risk. So those are the patients that you want to go after. You don't have to scare them. You just take a quick urine sample and make sure that they don't have protein in there. All right, so we're going to take a 10-minute break, but I wanted to insert a commercial into the break. Dr. Pham wanted to ask me to let you guys know that parking at Yale New Haven Hospital, remember that the really bizarre thing about CKD patients is that you're going to die of cardiovascular disease so much more commonly than they're actually going to die from renal failure. So we've got to intervene early, prevent that renal failure from occurring, but also try and modify some of those risk factors to avoid some of that cardiovascular mortality that we've been seeing. All right, so that was that in a nutshell. Now we can move on to preventing CKD progression once we know that it occurs. A lot of this, I think, is going to be common sense for you, but we'll fill in some of the details about your goals for these patients and some of the pathophysiology as well. So here are our CKD stages again. Again, don't memorize the numbers, just know that below 60 is a true moderate CKD diagnosis, and once you fall below 15, we're setting you up, you have end-stage renal disease and you will probably need dialysis. So for patients that have relatively normal GFRs, but you see markers of kidney damage, you're going to want to figure out how to address some of these progression factors that we're going to talk about, and you're going to want to try and modify their cardiovascular risk right away, so that we can prevent some of that early death from cardiac diseases. Once your GFR falls below 60 and you have kind of what we think of as a true decreased GFR, then we're going to want to follow you closely to see kind of if your GFR is declining very steeply or maybe not so steep, it's just slowly declining over time. And we're going to want to start evaluating you for complications of CKD. And we'll talk all about the complications on Friday. It's one of my favorite lectures for sure. Once you hit stage 4 CKD, we start to psychologically and physically prepare the patient for dialysis. It's a huge change, and so if we can start talking about it early, it's less shocking to the patient than just coming up to them and saying, your kidneys are done. Let's make sure that you come in 3 times a week to get your blood cleaned. So if we see this coming, we can kind of smooth the way for them to make a good transition. So the progression factors that we try to tackle to slow the progression of CKD include hyperglycemia, hypertension, protein in the urine. Remember, anytime protein leaks out of the glomerulus, it can be toxic to the tubules and cause even more kidney damage, and then obesity and smoking as well. We're really today going to focus on hyperglycemia, hypertension, and proteinuria. So let's look at hyperglycemia first. Hyperglycemia is probably one of the most toxic things to the kidneys that you'll see. We know that not only is diabetes the leading cause of chronic kidney disease, but if you have type 1 diabetes, you have about a 40% lifetime risk of developing some form of CKD. And if you have, and half of all patients with type 2 diabetes are going to have some form of kidney damage. And this can all be reduced if we can try and control hyperglycemia. I mentioned earlier that glucose actually binds to the proteins that make up the kidney. This binding is called glycation. So anytime you just have a lot of glucose floating around in your blood, the glucose will randomly bind to different proteins in your body, forming are known as advanced glycation end products. It's just a fancy way of saying you have proteins with glucose attached all over them. One semester when I taught this, one of the students really wanted to see a picture of an advanced glycation end product. I had a real hard time finding one, but I found a diagram. Here's just an example of an amino acid, lysine, that has a glucose molecule attached to it and actually has become, well, I guess a fructose molecule attached to it and has become fructosamine. You do not want glucose molecules attaching to your amino acids. It alters the functioning. It just doesn't let your kidney function quite the same way that it was supposed to. So again, I just wrote this out so that when you study, you can have a narrative to look at. When you have these advanced glycation end products, there's an alteration in the structure and function of your renal basement membrane molecules in your glomerulus. So there's increased oxidative stress, increased cytokine activation, and whenever you have cytokine activation, you're going to have kidney damage. Your kidneys are then going to try and hyperfiltrate to get over the kidney damage, and we're into that progressive cycle again. So most of what we know about treating hyperglycemia comes from what is now an older trial. It was published in 1993, but it blows my mind because think about it. Before 1993, we didn't know that intensive glucose control could help prevent microvascular complications. So this was a landmark trial that really changed how we practice these days. I feel like we have less and less of those now. Now we sort of find, very small sort of ways that we can improve therapies. This was like a dramatic trial. So it's called the Diabetes Control and Complications Trial, and it ran for 10 years between 1983 and 1993, and it randomized patients that were newly diagnosed with type 1 diabetes to either conventional control, so standard of care was like check your blood glucose twice a day. We'll try and keep it around 9, the hemoglobin A1C. And they said, let's have the intensive group try and normalize their blood glucose levels. So in the intensive group, patients had to check their blood sugars 4 times a day and aim for a hemoglobin A1C less than 6.5. Most of these patients were followed for about 6 years to see what happened. What they found was very, very dramatic. At the end of, after receiving about 6 years of intensive glucose control, they found that there was a 39% decrease in the risk for developing microalbuminuria, which is, small amounts of protein in your urine, and there was a 54% decrease in the development of frank albuminuria, which means having a ton of protein in your urine. So that's dramatic. I mean, you don't see study results that are that huge nowadays, although I'm sure we'll come up with something soon. The other really interesting thing about the DCCT trial was that after it ended, the study investigators checked back up with these patients like 8 years later, well after they stopped doing their intensive glucose control, and they found that even if the patient had then developed a higher hemoglobin A1C, they still had less retinopathy and still had less albumin in their urine. So strangely enough, controlling it early in the process will help you out even if you become less strict with your glucose control later in life. So here's just some figures illustrating these dramatic differences that you see. Most cardio trials, like these lines they slightly deviate, and you can say that that's statistically significant. These lines, the difference between the intensive and conventional care group are huge. So for example, with retinopathy, over the course of 10 years, you can see that the conventional group had a pretty steady increase in the number of patients with retinopathy, whereas the intensive group had a much slower increase. Finding a 76% decrease in retinopathy was crazy. The study investigators were hoping to find a 40%. They said this study will change practice if we can decrease retinopathy by 40%, and then it decreased by 76%, so that's pretty crazy. And then of course, don't forget, and it's so kidney-related outcomes as well. So interestingly enough, even though this study changed how we practice completely, the current kidney guidelines that are put out by KDOQI, which is the Kidney Disease Outcomes Quality Initiative, suggest shooting for a hemoglobin A1C of approximately 7. You would think that based on the results of that DCCT trial that you would shoot for less than 6.5 because that's what the intensive group did. But what they found is even though the intensive group shot for a hemoglobin A1C of 6.5, at the end of the trial, most of them really had a hemoglobin A1C of 7.2. So even though the goal was less than 6.5, none of them made it, and they still had these amazing results to the study. The other thing that isn't mentioned as much when people talk about the DCCT trial is that there was a 3-fold increase in severe hypoglycemia in the intensive group. By severe hypoglycemia, I don't mean somebody felt dizzy and ate a glucose tablet. I mean that the patient needed to be assisted by someone else. Either somebody found them and helped give them glucose, or they were admitted to the hospital. And there was a 3-fold increased risk of seizures and comas related to hypoglycemia as well. So even though this intensive group did better, there were some serious adverse effects. And CKD patients in particular tend to be very prone to hypoglycemia. Remember I mentioned that if you have a liver transplant, you won't become hypoglycemic because your kidney can kick in and do some of the gluconeogenesis that's required. If you have chronic kidney disease, your kidney can't help with gluconeogenesis, and insulin products tend to have longer half-lives in these patients. So given the fact that these patients never even got to 6.5 and hypoglycemia is an issue, the KDOQI guidelines say to shoot for hemoglobin A1C of approximately 7. I've never seen a guideline say approximately something. It used to say less than 7, but thinking about these results, they said around 7 is just fine. So that's what we do for glucose. We do want it under control to prevent the formation of those advanced glycation end products. So next, let's talk about hypertension. Remember again that hypertension damages the kidneys because it damages all of your arteries by putting pressure on them. And so it will damage your renal artery and your glomerulus as well. So of course, we're going to want to try and treat hypertension. And antihypertensives can help in 2 different ways. The first way is by reducing your overall blood pressure. If you're reducing your overall blood pressure, then you're reducing the pressure put on your renal arteries and the pressure put on your glomerulus. So anytime we start a blood pressure lowering agent in a patient that is hypertensive, we are helping to protect their kidneys. Crazily enough though, there are some specific blood pressure medications that also seem to reduce proteinuria. We're not even exactly quite sure how this works, but we've found that ACE inhibitors, ARBs, and non-dihydropyridine calcium channel blockers decrease the amount of protein that comes out of your glomerulus. And if you can decrease that amount of protein, you'll decrease the toxicity that occurs to the tubules. So that's a really big deal. Do you guys remember? You've had cardio, so I'm sure this is easy. What's a non-dihydropyridine calcium channel blocker? What are some examples? Good. So no prescribing like nifedipine or amlodipine. We're looking for the non-dihydropyridine ones because in trials they performed a lot better than the dihydropyridine ones when it came to reducing the amount of protein in the urine. As far as the target blood pressure that you should use when treating hypertension in patients with CKD, there is a little bit of controversy here. The new JNC8 guidelines and the ADA guidelines suggest a blood pressure of less than 140 over 90. However, if you pull the kidney-specific guidelines put out by KDOQI and KDIGO, they still recommend a blood pressure goal of less than 130 over 80. To be honest, when I went back through the kidney guidelines and tried to look at why they picked 130 over 80, it was based on some very small studies. So I think when JNC 8 came out and said, we're only going to use these randomized controlled trial results to come up with our recommendations, that's why they went with the 140 over 90. I think both of these answers are reasonable. I think just be sure to cite which guideline you want to use when you decide what blood pressure to shoot for. To be honest, I'm kind of leaning towards the 140 over 90 because, again, these trials were pretty small that suggested a lower blood pressure. ACE inhibitors and ARBs are the ones that are the classes of medications that reduce proteinuria the most. So those are our first line go-to agents in patients who have diabetes or patients with chronic kidney disease that have protein in their urine. And then if for some reason they're not responding to the ACE inhibitor or ARB or it's contraindicated, then you can go for the verapamil or the thiazide type thing. This is a slide and we don't need to remember it for now, but verapamil is incredibly constipating, so still thiazide if you're going to go with a non-dihydropyridine calcium channel blocker. Finally, one more important thing to know is that if you've got a patient with a huge amount of protein in their urine and you think that it's causing them to progress into kidney failure, you're not going to care what blood pressure there is. You won't care if they're 120 over 80. You're going to start an ACE inhibitor to try and decrease the amount of protein in the urine. So even if the patient's blood pressure is at goal, if they have a huge amount of protein in the urine and you need to get it under control, you'll start an ACE inhibitor even in somebody who doesn't have hypertension. Just be sure not to bottom them out at the same time. All right, so try and focus for this slide because I feel like this is the most common question I'm asked, and I had to stop and ask myself this question when I got that too. So if ACE inhibitors cause acute kidney injury, why are they so helpful in chronic kidney disease? The way I think about it is that when you, let's see, I'm going to start with an analogy first. Say that you are a P3 pharmacy student at UConn, and you heard that P3 year was really, really hard. There are two ways that you could respond. You could go to class, every day come home and study, and then go straight to bed and repeat. Never have any fun. Your grades are going to start out fantastic, but as the wear and tear of working harder than normal gets to you, your grades might dip as you burn out. Now take someone who maybe puts less pressure on themselves, works hard, but doesn't overwork or hyperfiltrate is what I'm trying to get at, but that makes no sense. If you take the time to relax a little bit over the course of the semester, your grades are going to stay strong instead of tapering off as you burn out. The same thing is true of the kidney with ACE inhibitors. Remember that when kidney damage occurs, your kidney tries to step up by hyperfiltrating so that you don't see a decline in GFR. The way that the kidney hyperfiltrates is by releasing angiotensin II. Angiotensin II clamps down on that efferent arteriole, increasing your intraglomerular pressure so that your GFR is normal or sometimes even higher than normal as it's hyperfiltrating. When you start an ACE inhibitor, this sort of undoes the ability for the kidney to hyperfiltrate. So your GFR goes down at first because your kidney is being forced to relax, but over the long run, being forced to relax means that there's not going to be as much wear and tear on the glomerulus. So when you start an ACE inhibitor, your GFR declines a little bit, but then it's going to stay more steady than if you didn't start that medication. Does that make sense? Anytime you've got something working too hard, we've got to get it to calm down or it's going to burn out. Students, kidneys, hearts. There is one other, so we think that the reason ACE inhibitors are so nephroprotective are the effects on that efferent arteriole. There is one other theory that has been shown in animal models that says that ACE inhibitors, ARBs, and those non-dihydropyridine calcium channel blockers seem to decrease the pore size of those pores in your glomerulus so that proteins can't get out. I have no idea how that mechanism would work, but I just wanted to let you know there are some different theories. All right, this is just another figure with dramatic results to show you that if you put a patient on an ACE inhibitor like captopril, even for as little as 3 years duration, you will see some dramatic effects in preventing the progression of chronic kidney disease. So finally, I just wanted to review with you a couple tips about starting ACE inhibitors in your patients with CKD. If you have someone with a large amount of protein in their urine and you need to get it under control, go ahead and start the ACE inhibitor and titrate it up every 4 weeks to the maximum tolerated dose. You don't have to think about blood pressure goals in this case. You just want to get the biggest dose possible in those patients to try and stop this protein leaking out into the urine. Some physicians will increase the dose until they see the protein in your urine actually reduce by 30 to 50%. So if you're a young person who can handle a blood pressure of 110/80, we'll titrate that ACE inhibitor all the way up until you start feeling side effects, because we want to reduce that amount of protein in your urine. We will tolerate, you'll see that serum creatinine rise, and we'll tolerate it. In fact, we'll say, oh look, the drug is working. Your serum creatinine is increasing up to about 30% above baseline. If your serum creatinine shoots up more than that, then we start to worry and we might discontinue it, hydrate you, start with some lower doses. But that's what we're looking for. And this is in line with what you learned in cardio too, right? 30%? Okay. All right, so then without looking at the next slide, I know you guys will be pros at this. What do you monitor when you're starting ACE inhibitors? Cough, yeah. We would look at, if they develop a cough with an ACE inhibitor, we could consider switching to an ARB. I know a pharmacist that got a cough with an ACE inhibitor and said, I'm going to deal with it. I think ACE inhibitors are important. So if it bothers them, you would switch. What else? What other side effects of ACE inhibitors are there? Hyperkalemia is a big one. In these patients, your kidney is responsible for filtering that potassium, so we do have to be careful about monitoring that hyperkalemia. What else? What is that? Hypotension, right. I mean, I'm telling you guys to be aggressive, but don't kill your patient by titrating that up too high. Okay, those are some biggies. Let's see if I have any. Yeah, those are my big ones that I decided to highlight. Of course, don't give it to any pregnant ladies. So just a summary slide to help you study. Your goal blood pressure in most patients is going to be less than 140/90. So if the patient has diabetes, less than 140/90. If they have CKD without diabetes or protein in the urine, it's also less than 140/90. There is this controversy about patients that have some protein in their urine about whether you want to shoot for 140/90 like JNC8 says, or if you want to go with the kidney guidelines that say less than 130/80. So just know there's some controversy there. And then of course, if somebody has frank proteinuria and spilling large amounts of protein in their urine, we don't really care what your goal blood pressure is. We're going to titrate up that ACE inhibitor. Sometimes when you go to residency interviews, they'll ask you, if you were a drug, what drug would you be? I think that would be an ACE inhibitor because they just they're helpful in CKD, they're helpful in diabetes, they're helpful in CHF, they're helpful in MI. It just seems to be a universally helpful drug. Just be sure to monitor me carefully so I don't give people hypotension or hypothermia. I I'm such a fan of ACE inhibitors, they had to throw this slide in here. This is a really old study now, from 1997, but and the rates of ACE inhibitor use have increased since then, but I think it's a really good call to action about you guys as pharmacists helping to make sure that patients with CKD receive ACE inhibitors. So what this study was they pulled data from the Medicare beneficiary database, and they looked at people with diabetes or hypertension that had been recently hospitalized. What they found was that if a patient with diabetes was hospitalized, and during that hospitalization they found protein in the urine, only 33% of these patients were discharged on ACE inhibitors. This is like a classic reason to be on an ACE inhibitor, and it was only getting prescribed a third of the time. For patients with hypertension and protein in their urine, only 13% left the hospital on an ACE inhibitor. And even more profound, these patients with really high serum creatinines with diabetes and hypertension were not receiving ACE inhibitors at discharge as well. So when you are on rotation in the hospital, keep an eye out for patients that have CKD who are not on ACE inhibitors. You can really help them protect their kidneys, and there's probably some mortality benefit because they probably have diabetes or CHF and things like that as well. So I want you guys to be very pro ACE inhibition, even though it causes a little bit of AKI in the beginning, it's helpful in the long run. I'm going to leave you with just one interesting thing that you probably don't even need to study, but I wanted to show you that there is a U-shaped blood pressure curve for patients with end-stage renal disease. What I mean by that is, if you look at these different systolic blood pressures here on the x-axis, and you look at the relative death rate on the y-axis, you can see that there is a high death rate if you've got a systolic blood pressure above 170, which is what you would expect. But patients that have really low blood pressures also have very high mortality rates. Now this is probably because your very sick patients might have trouble keeping up a nice healthy blood pressure, but I just wanted to point that out because when you're looking at your dialysis patients, I don't want you to say, oh, their blood pressure is 100/50, that's great, keep it up. I want you to say, oh, maybe we should be pulling back on some of these blood pressure medications. It's not good to cause somebody to have a blood pressure that's too low. All right. If you can control hyperglycemia and control hypertension, you are doing a huge favor to your patients. There are a couple other interventions that I'm going to review with you, but they aren't as robust as making sure that your patient has an ACE inhibitor on board. One thing that we do think is probably helpful is for our patients that have failing kidneys and so have developed very profound anemias, that if we can treat the anemia, that will help take some of the pressure off of the heart and off of the kidneys. So treating anemia can slow the progression of CKD, and we'll talk about that a lot on Friday. Protein restriction has also been floated as a possible idea to slow progression. The theory behind this is that when you eat proteins, they get broken down into nitrogenous waste products, and maybe those waste products building up in your blood could be toxic to your kidneys. So they tested this theory in a large randomized controlled trial, which is actually where they got the data from the MDRD, Modification of Diet in Renal Disease study. And what they found is for most patients, protein restriction is not helpful. There is one subset of patients where it does seem to help, and that's patients with a GFR less than 25 mils per minute. So very severe chronic kidney disease. So you could consider restricting protein in those patients. Once the patient starts hemodialysis, be sure to let them eat lots of protein again because we're clearing out the waste products with the dialysis procedure. So we don't need to limit protein in hemodialysis patients. I would not necessarily recommend protein restriction for everyone with a GFR less than 25. I think you need to take a look at your patient. if your patient has a bunch of waste products in their blood that has made them lose their appetite and they're not eating anything anyway, I would be really hesitant to restrict their protein because eventually they're going to become malnourished and die from that instead. So you only want to restrict your protein in patients with a GFR less than 25 that still are functioning well and have a healthy appetite and are willing to try this modification. All right, so we're on the home stretch now. I just have to have a spiel about modifying cardiovascular disease as well, because that's what kills these guys anyway. We can try and slow the progression of CKD all we want, but if they're going to pass away early from cardiovascular disease, it seems like a big shame. So remember that half of all patients with end-stage renal disease pass away from cardio stuff, not renal stuff. And so it's very important that we treat hyperlipidemia, that we encourage smoking cessation, that we encourage exercise, because these are the things that are going to keep them healthier in the long run than trying to stall the progression of the CKD. I'm gonna let you guys refer to your own smoking cessation notes for that, but I am gonna talk just a little bit about hyperlipidemia treatment in these patients because there's a really interesting caveat about using statins in these patients. So the first thing to know is that anyone with CKD should be treated as someone who has a cardiovascular equivalent, that they have cardiovascular disease. The old goal that I used to teach students back when we targeted different LDL goals was that you wanted their LDL less than 100. So pretty aggressive LDL lowering. I would still go ahead and memorize 100 because I think it still might come in handy to know, if you check somebody's lipid panel, to know whether you think their LDL has been aggressively lowered or not. The latest Kidney Disease Improving Global Outcomes Guidelines recommends statins in any patient who is greater than 50 years of age that has a GFR less than 60. So see how that 60 comes into play a lot? Anytime you have a moderately decreased GFR and you're above 50, statin therapy is probably a good idea. The other caveats are just like you learned in cardio. If the patient has known coronary disease, if they have diabetes, if they have a stroke, or if you calculate their cardiovascular risk and it's above 10% that they'll have an event in the next 10 years, then you would go ahead and start a statin as well. Just so you know, the kidney guidelines do go ahead and point out that the statins atorvastatin and fluvastatin are not renally eliminated, and so you don't need dose adjustments if you pick one of those agents. However, you can use any agent as long as you dose adjust it. So I don't want you guys to be scared of dose adjusting things because you guys are pharmacists, and if anyone can do it, you guys can. All right, so the reason that I think hyperlipidemia in these patients is so interesting is that even though there's been proof that statin therapy reduces cardiovascular risk in patients with CKD stages 1 through 4, nobody has ever been able to prove that patients with stage 5 CKD, your end-stage renal disease, patients on dialysis, no one's ever been able to prove that statins help that population. This drives the statin drug companies nuts because statins are a multi-billion-dollar industry. The companies have funded studies that have shown statins should be in the water. There'll be a public health thing. Everyone should be on a statin. So it drives them crazy that they cannot prove that dialysis patients need statins. In fact, they funded some large randomized controlled trials. The 4D trial. The 4Ds is it's a German study, so it's like Der Deutsch Diabetes Dialyse trial. I'm sure I said that all wrong. And I forgot what Aurora stands for, but one of the R's is rosuvastatin. And those two large randomized controlled trials found no benefit of the statin in hemodialysis patients. So some theories about why this might be true is that, one, remember that these patients with CKD have all of those non-traditional risk factors that most patients don't have. Maybe statins aren't the answer to treating some of those non-traditional risk factors. But the statin companies also pointed out that patients enrolled in this trial already had pre-existing cardiovascular disease. So maybe it was too late to help these patients with a statin. So because of that, they funded one more trial that came out in June 2011. This was the study of heart and renal protection. It enrolled a huge amount of patients for a chronic kidney disease study. Over 6,000 patients with CKD stages 1 through 4, and over 3,000 patients with hemodialysis. And they made sure to get patients without prior heart disease. I don't know how they found these people. It must have been a lot of work. They had a placebo group and a treatment group, and the treatment group received a statin and also Zetia. Did you guys learn about Zetia in cardio? Okay, it's probably so out of favor, I don't even see it very often. But anyway, they received this combination, and there was a 5-year follow-up, and they looked at the primary outcome of this kind of composite of MI, coronary death, ischemic stroke, or revascularization procedures. And what they found, now of course this is so much less dramatic than the DCCT trial, but what they found was there was a reduction in that composite end group in this large group of patients that were enrolled in the study. So the statin company said, hooray, everybody should be on statins. Look at how we've decreased risk. But what happened is when we pulled out the data from the hemodialysis patients, there was no improvement in outcomes. So once again, they've really failed to prove to anyone that dialysis patients need statins. So the bottom line regarding this is that there does appear to be mortality benefit in patients with CKD stages 1, 2, 3, and 4, as long as your patient qualifies by being over 50 and having a GFR less than 60. There's even some thought that statins could slow the progression of CKD, so that would be a double benefit perhaps. But because there's no mortality benefit in patients with end-stage renal disease, the kidney guidelines say do not bother starting a statin in these patients. And I'm making a big point of it because I see dialysis patients on statins all the time, and it just seems like another medication that could possibly give them side effects with no proven mortality benefit. So, yes?
If they were in stage 4 and progressed to stage 5, could you just take them off it?
Excellent question. The guidelines right now say there's not a lot of evidence either way, but that they would probably keep the statin on if they happen to be on it and tolerating it well. All right, and then because I'm obsessed with U-shaped curves here, I just wanted to show you that cholesterol follows that same curve that I pointed out with blood pressure. On the x-axis, we have serum cholesterol, so total cholesterol levels, and on the y-axis, we have a relative risk of death. Clearly, there's an increased risk of death if your cholesterol is allowed to get above 350 in your dialysis patients. But look at when the cholesterol gets low, there's even a much higher risk of death if your cholesterol is 150 or less. And the reason I'm pointing it out is that when you take a lipid panel of your dialysis patient, don't be like, oh great, their LDL is 60, let's leave them there. To be honest, a lot of these patients are probably getting malnourished, and that's why they have such low lipid levels. So just don't necessarily celebrate the lipid results until you take the whole patient into account and say, is this just great therapy or are they getting malnourished? So here is the main summary slide. I think if you squish this in, your pen will be pretty good. Everything else is details, which will be important to study, but the main ideas are we want strict glucose control, but not too strict, approximately 7 for your hemoglobin A1C goal. We love ACE inhibitors and ARBs. And second line would be dihydropyridines for decreasing the amount of protein in your urine. You do want to treat hypertension. Most guidelines will say less than 140 over 90 for your target, but remember there's a little bit of controversy with JNT8 and the KDOQI guidelines. You're going to want to start statins in most of your patients to help them not die so early with cardiovascular disease, but remember that dialysis patients don't need to be started on one. Smoking cessation, weight reduction, and exercise is good. And then do know that protein restriction can help a very specific subset of patients if they're open to it, but it's not something that you would prescribe to everybody. All right, that's all.